Surgery has long been the standard treatment for resectable colon cancer, typically involving removal of the tumor and nearby lymph nodes. While it remains the primary option, recent trends show a gradual decline in surgical use, even among strong candidates. This shift does not reflect reduced effectiveness, but changing treatment decisions shaped by individualized care, patient preferences, and evolving healthcare approaches. The data behind the decline. Recent studies show fewer stage 1 to 3 colon cancer patients are undergoing surgery immediately or at all. An aging population with chronic conditions like heart disease and diabetes has shifted treatment decisions. For many older patients, the risks of surgery and recovery may outweigh the potential benefits of tumor removal. The rise of non-operative management and targeted therapy. Another major factor is the continued improvement of non-surgical cancer treatment. Advances in chemotherapy, immunotherapy, and targeted therapies have expanded the range of options available before surgery is considered. The idea of organ preservation, first discussed more heavily in rectal cancer treatment, has also started influencing conversations around colon cancer. Some patients who receive neoadjuvant therapy, meaning treatment before surgery, experience what clinicians describe as a clinical complete response, where scans and biopsies no longer detect visible tumor tissue. That creates a difficult decision. Surgery remains the most reliable way to confirm removal of disease, but some patients are increasingly willing to consider close surveillance instead of immediate resection, particularly if treatment has already produced a strong response. Avoiding a major abdominal procedure, along with possible complications or lifestyle changes afterward, can be a strong incentive. This discussion becomes even more relevant in patients with specific molecular profiles, especially those with microsatellite instability high MSIH tumors, where immunotherapy has shown unusually strong responses in some studies. Socioeconomic barriers and access to care. Limited access to care is another major reason many patients do not undergo surgery. Rural hospital closures, shortages of surgeons, long travel distances, financial strain, and recovery challenges can delay treatment. As a result, some patients choose less invasive therapies focused on symptom management rather than long-term cure. The psychological shift, quality of life versus longevity. Patient attitudes toward treatment have shifted, with many valuing daily function and independence as much as survival. Concerns about recovery, complications, bowel changes, and loss of independence can make surgery feel too disruptive. As shared decision-making becomes more common, physicians increasingly discuss risks, benefits, and alternatives, rather than presenting surgery as automatic. This sometimes leads patients, particularly those expecting only modest benefits, to choose more conservative treatment options instead of surgery. The impact of screening and overdiagnosis. Improved screening may also explain part of the decline. Colonoscopy programs are identifying more very early lesions, including cancers that are still highly localized. Because of that, some abnormalities that once would have led directly to surgery are now managed endoscopically. Techniques such as endoscopic submucosal dissection, ESD, allow specialists to remove certain early-stage cancers without traditional surgery. For selected patients, this means treatment can happen in an endoscopy suite rather than an operating room. As these methods become more common, they naturally reduce the number of formal surgical resections recorded in treatment data. Where surgical decision-making is headed. The decline in surgery for resectable colon cancer does not point to a failure of modern treatment. More often, it reflects a field adjusting to new therapies, better screening, and a broader understanding of patient priorities. At the same time, the trend deserves careful attention. In some settings, reduced surgical treatment represents progress in personalized medicine. In others, it may reveal unequal access to care or delayed treatment caused by systemic barriers. The goal moving forward is not simply to preserve surgery rates or lower them further. It is to ensure that each patient has access to the treatment most appropriate for their condition, circumstances, and preferences. Colon cancer care is becoming more flexible, but that flexibility only works when patients are fully informed and genuinely able to choose.